So thank you right at the outset for Dr. Gera sir and the whole Pushpanjali team, Dr. Vinay, Dr. Manish and everybody for the love and affection and inviting me here to present this wonderful, very important topic which is part of everybody's prescription day in, day out. Whether the sun is there or not, vitamin D stays on the prescription. So we'll try to make some understanding about vitamin D deficiency in adults and how are we supposed to approach it. We'll learn few basic concepts and few trials, few data, and what should be our ideal prescription. Are we closer to the ideal prescription or not? So, the sun, that is the ARK, is the radiant and the very source of life. It is the prime giver of vitamin D. And it is the sun which nourishes the body always, blesses us with the health, and it is the sacred deer of ourselves like dharma. So the sun has a lot of importance. But why are we discussing vitamin D? What is the importance of vitamin D? It has the role in calcium absorption. It has role in immunity. It gives power to our muscles and bone. It makes us move. Despite the sun being everywhere, the prevalence of vitamin D is rampant. It's all across the globe. Does it affect any single specialty? No, it affects the whole mankind. So it belongs to us all. People in medicine, ortho, gynae, oncology, immunology, even in psychiatry. So while it is important to put the sunscreen to keep your beauty all along, but at the same time, it is important to sit back and relax, have a cool attitude, take some sun. So we have to strike the right balance of both. So let's get some sun. Every day it's all around. We have to just find the right time. So the midday sun is very important from 11 a.m. till 2 p.m. We'll understand why that time is important. Because if we do not get enough sun, this is what happens to our skeleton. It gets weaker and we get fractures, we fall. So we'll be like the whole burnt out if we do not get adequate sun. So it's very important that we keep the vibrancy, we take enough sun daily, and we keep our skeletal health so that we can dance all throughout our life with a bone mineral density to a score of just -1, not more than that. So guys, we'll try and understand, we'll try to dig what we can do extra in our prescription while we sip in our adequate dose of vitamin D or take it from other sources. So the importance of vitamin D deficiency, we all know it's sunshine vitamin. It's vital for varieties of things apart from bone. It has role in calcium absorption, immunity, muscle and bone strength. While it can be absolutely asymptomatic when it is mild, it can give rise to bone pain and weakness when it is moderate, and when it is severe, it can give rise to fractures and osteomalacia. The treatment we all do day in, day out, we'll try to understand what are the guidelines saying. So first, the definition. According to various bodies, it has been found that deficiency is when it is 12 nanogram per ml or less. And which vitamin are we measuring? Are we measuring vitamin D, vitamin D2, D3? What are we measuring? So we are measuring 25-hydroxy vitamin D. It's irrespective of D2 or D3, right? So this is nanogram per ml. The unit is also very important because once we see the report from certain labs, it's in millimoles per liter. So nanogram per ml has to be multiplied by 2.5 to get into the millimoles per liter. So one of the lab is giving it in millimoles per liter, rest of the other labs are giving in nanogram per ml. So we'll stick to nanogram per ml and we'll understand that we have to multiply 2.5 if we are talking about millimoles per liter, right? So for our clear understanding, when it is less than 12, it is deficiency. Between 12 to 20, it is insufficiency. And more than 20 is sufficient. Then we talk about adequate and supranormal as we reach towards 30, 50, 60 and high doses to maintain the levels as good as towards 60 to 80. Once it goes beyond 100, so they have marked it as that more than 100 nanogram per ml can give you toxicity. So what are the sources of vitamin D? The sun is the source, if we can get it adequate. Otherwise, the food. In the food, we can get it from plant-derived source, we call it ergocalciferol, that is vitamin D2. So plant-derived is mainly from, you get from the fungi that you eat in your food, but many people do not eat the mushrooms, right? So only source for the vegetarian people is still sun or the food fortification. While for people who are taking non-veg, they can still have a source through the non-veg food items, but then it is not so rampant as is the sun. So this is the sources in various food sources. So mushrooms can give you as good as 800 units, and cod liver oil can give you as good as 1000 units plus, but the rest of the food fortified will give you just 100 units or around. While you see the bottom line, that is sun, if properly utilized, can give you as much as 25,000 units in a day, right? So you have to understand that while we need roughly 600 to 800 to 1000 units a day, sun can give us the whole supply, but we need to understand which kind of sun, where and how much. Or we need to fortify our foods, which our government is initiating steps, but is yet inadequate. But still they are going to be just in range of 100 units. So what is the global prevalence? So the global prevalence is very, very rampant. We see in our OPD practice, I don't think we need to look at the globe even. Our OPD practice probably would be 70 to 80% are deficient. And across the globe, 15% are depleted from vitamin D. So even when we say how many people are sufficient vitamin D levels, it is again 15 to 30% are having sufficient vitamin D levels. So we have a lot to do and a lot to care. So what is happening? What is the pathway? That if you get less sunlight, you get less vitamin D, you get less 125 hydroxylation, that is calcitriol, you get less calcium absorption in the gut, there is increased PTH. Once your calcium is low, so vitamin D, what is the significance? It's not vitamin D. You write the prescription, डॉक्टर साहब कैल्शियम तो हम ले रहे हैं, वो भाई तुम कैल्शियम नहीं ले रहे, तुम विटामिन डी ले रहे हो. विटामिन डी एडिक्वेट कैल्शियम एब्जॉर्प्शन करेगा अगर बॉडी में आ रहा होगा. इफ योर फूड सोर्सेज हैविंग एडिक्वेट कैल्शियम, तब विटामिन डी आपकी बॉडी में एडिक्वेट कैल्शियम पहुंचाएगा. दैट टू अगर आपको कोई मेल एब्जॉर्प्शन डिफेक्ट नहीं है, आपकी सर्जरी नहीं हुई है और आपकी फूड सप्लाई में विटामिन डी कैल्शियम एडिक्वेट मात्रा में, तभी विटामिन डी कैल्शियम एब्जॉर्प्शन करेगा. द सोल रोल ऑफ विटामिन डी इज कैल्शियम एब्जॉर्प्शन as we talk about the skeletal health. So once you do not have calcium, the low calcium would raise the PTH. So this raised PTH is giving hyperparathyroidism and your bones are getting lysed. That's why भगवान ने हड्डियाँ बनाई थी. They are the storehouse of the calcium. कि नहीं खाएंगे तो हड्डियों से निकाल लेंगे. That's why the serum calcium level is not altered so easily. But your bones continue to get weak. You do not get low calcium, you don't get tetany, you don't get arrhythmia, because the God has been designing your body so well that your bones are to be preserved. They are the storehouse of the calcium which you need to keep intact to move at age 100, at age 80. But if you do not keep it, your supply is strong, then your bone continues to get depleted and you have fractures, fall, asthenia. So decreased bone mineralization giving rise to osteomalacia. So coming back to the clinical manifestations, once the deficiency is just mild, you may be asymptomatic or you may have slight pain. Once the deficiency is to the range of 10 to 20, you have bone pains, weakness, and once it is less than 10, you have osteomalacia and fractures that is severe. So how is vitamin D getting synthesized? So what is the role of this ARKA? What is the role of this sun? How is it doing it? So sun has the beautiful rays in all ranges of wavelengths. So you get the UVB, which is important, in range of 270 to 320, but more important is the UV index. So that UV index has to be appropriate so that you get this UVB adequately in your body, and then it takes its next steps. So this sun rays cross the barrier of clouds by the latitude where you are living, by the season of the day, by the time of the day, by the angle of the sun rays. The UV index is decided. Once these sun rays strike the skin, the 7-dehydroxycholesterol in the skin, that is pre-vitamin D, is converted into cholecalciferol, that is vitamin D3. After that, it is the role of liver, that is 25 hydroxylation, and then the kidney, that is 1 hydroxylation. So no LIV52, it is 25. Liver is 25, not LIV52, right? So it is liver is 25 hydroxylation, which gives you calcidiol, and then it goes to the kidney. 1 hydroxylation is further done, you get the calcitriol. So you have on your prescription calcitriol also, you have your prescription with calcidiol also, you have your prescription with vitamin D also, and you have your prescription with injections of vitamin D also. So you have to see how many ways you are giving your patient vitamin D and for what purpose are you giving these multitudes of vitamin D. So your prescription has to be synthesized appropriately, understanding what is calcidiol, what is calcitriol, and what is vitamin D, as we know, D2 and D3, right? And how much are you getting from the diet? So before you prescribe, you need to ask your patient, what are his sources of vitamin D? How much is he getting himself exposed to the sun? How many times he has taken those sachets of 60K units that each and everybody is prescribing, and how many times he has been injected with the vitamin D? It's good to ask, only then you go ahead with your prescription, unless you have checked vitamin D levels. So this is pathway for your revision again. 7-dehydroxycholesterol in the skin, one exposed to the UV light, we get cholecalciferol, that is vitamin D3, or from the food sources, as the food is also exposed to the sun, like the fungi I said, you get the vitamin D2, ergocalciferol. In the liver, it goes to get the 25 hydroxylation, 25 hydroxy, that is calcidiol, and then in the kidneys, 125 hydroxy, that is calcitriol. It is very important to understand, we keep getting confused between vitamin D, D2, D3, and all these various forms. So who are at risk? When we were studying in MC, it was told to us way back 1990 that जो बुरके वाले जितने आते हैं ना जामा मस्जिद से, उन सबको विटामिन डी जरूर लिखना है. So our seniors have been so wise right from the beginning that we have been writing vitamin D to all the people who were coming in the burqa. Now we all are burqa clad. Once we get up, we are in our cars, then in our offices. So we are all throughout in burqa, or even if we get the sun, we get the sunscreen before we exit. So the burqa is there all around us. Pregnant women again are at risk. Those individuals who are having malabsorption, they can't absorb adequate vitamin D supplied orally. And those who are obese, because of excess fat, the vitamin D is sequestered in the adipose tissue more and it's released lesser. So they are again also obese. Then people who are taking multitudes of drugs, antifungals, those who are taking anticonvulsants, they also are vitamin D. So these are good number of people who are vitamin D deficient by their virtue. Apart from, we all are universally in burqa, so we all are deficient. So again, coming signs, symptoms, I think we have already discussed. What are the biochemical and diagnostic changes? If you do not get the vitamin D levels, what are you expecting in the blood? So first thing, you look up at the calcium. The calcium would be low. You look up at the phosphorus, would also be low, because same vitamin D absorbs calcium and phosphorus, both would be low. And the response, the alkaline phosphatase, which is derived from the bone, would be high. So these are the indirect ways that you can look up whether you are over treating your patient or under treating your patient by this biochemistry. And our nephrology colleague very commonly orders serum PTH, because they are more wiser in calcium, bone mineral metabolism than rest of us. That's why they get the PTH. If the PTH is high, that means it has to be supplemented adequately so that the PTH is low. So that's our goal and target, because we do not want the bone mineral density to go down. So this is what is important. What is the goal of our treatment? Goal of our treatment is not just to achieve 20, 30 nanograms. That is a biochemical goal. Our goal is to have a normal calcium and PTH, and final goal in the life is to reduce fracture risk and the fall risk, that we can continue to be mobile. Again, one important basic concept. Anybody knowing what is zenith and zenith solar angle? So zenith is from our head to our foot. That is the line is known as zenith. That the horizontal line that passes from our head to the foot is the zenith. And what angle the sun makes with this horizontal line is the zenith solar angle. So this solar angle is very important. That's why we talk about Uttarayan ka Suraj. Delhi is 28° north by latitude. When Uttarayan comes, the sun comes 23° north. So during Uttarayan ka Suraj, which just passed 21st June, that time 5° is the zenith angle because the sun is just at 5° because it's about Delhi, 28° north and sun 23° north. So zenith angle in the middle of the day, 12:15 p.m. would be just 5°. That is the highest peak of the sun rays that you get. So you will be very easily synthesizing UV B related vitamin D in your body. So that is the importance of zenith angle. Then comes importance of UV index. The sun is rightly positioned, but are the rays able to travel to your skin or not? So this is UV index, London yesterday, where my daughter is living, and she is working on a project, skin and kin. So she is working on sensitization of children to prevent UV related damage to their skin. So she is working on sunscreens, and here today she has been award winner for one of the projects which was at international level, just happened just last month. So here I am presenting the importance of sun. So where is the right balance? Applying the sunscreen on one side, on the other side getting the adequate sun to get the vitamin D. So here in Delhi, UV index is generally between 2 to 5 or 3 to 5. So that is supposed to be adequate UV index to synthesize reasonable vitamin D, but then the exposure time is going to be longer. While in London, there are 6 months that you won't be able to synthesize vitamin D by any means because the UV index continues to be low. So this is about UV index. So UV index range, and this is the balance of skin type and darker skin type. So London being skin type 1 and 2, Delhi being skin type 3 and 4, South India being skin type 5 and 6. More darker, more melanin, more is the intolerance to, or more lesser is the passage of those UV rays. So you would have less than 3 UV index, just use supplement. If the UV index is like Delhi, 5 to 10 minutes, no sunscreen, get the UV rays and then apply the sunscreen if you are fair skin type. If you are darker skin type, then 10 to 15 minutes, no sunscreen, then get the sun. If your UV index is 8, like in Ibiza, Spain, on those beautiful beaches, you just need 5 minutes of skin exposure and you get adequate vitamin D. While if you are darker skin type there, you will still need longer skin exposure. So if you are in beach in Ibiza, you just need 25% of the body exposed to 5 to 20 minutes of sun exposure to get adequate vitamin D. But if you are in Delhi, Red Fort Beach, Delhi, then you need to expose because you have enough pollution. Once you have a AQI which is 100 or lesser, the UV rays come straight down. But if you have AQI 100 to 200, they are obscured by around 50%. If you have AQI which is more than 300, then the UV rays are almost all blocked. They do not reach down. So on this Red Fort Beach, there would be days you will need to just expose 25% of your body for 25 minutes. There would be days that you will have to be all in your beach wear for more than 60 minutes to get your adequate vitamin D. So that's why we are never exposed that way, and we need vitamin D exposure adequately or supplements. So going to the treatment protocol. So once vitamin D is very less than 12, we all are prescribing roughly 60,000 international units every week. Most of our prescription to our patient is saying 8 weeks, and then we'll recheck. So we need to understand what is the rate of rise once we prescribe these things. Once we prescribe roughly 1,000 units, then it increases 1,000 units per day if we prescribe, then it increases roughly by 10 nanogram. that too over 6 to 8 weeks. So if somebody is at 10, that means after 6 to 8 weeks, he will be at 20. And if you keep going, it will keep increasing. So by third or fourth month, you will be reaching to 30 nanograms. That would be the adequate levels. So that's the rate of rise that we all need to understand. If we give injectables, then by end of 2 weeks or 3 weeks, you will be getting to the sufficient levels of vitamin D. And the literature says if you are correcting the very severe vitamin D deficiency, please recheck after 3 to 4 months. So in those patients, this is from up-to-date guidelines that once vitamin D is less than 12, you start with oral vitamin D, roughly 30 to 60,000 IU every week for 8 weeks, and from week 9 you will be giving 800 to 1000 units per day to the patient. It is said that if you mimic the daily dosing, it is best and physiological. If you give the bolus dosing, there are certain literature that though it is helpful, but it is not as good as the physiological way of correcting and supplying the vitamin D daily, right? So if the deficiency is to 12 to 20 nanogram, then you need not hush, you need not give bolus dose, you just supplement with 1000 to 1200 units daily. The literature says 800 to 100 units daily. Again, 40 IU is 1 microgram of vitamin D. As insulin syringe, we can remember 40 IU is 1 unit. So 40 IU vitamin D is 1 microgram of vitamin D, right? If you want to talk about micrograms. Same if it is 20 to 30, then continue with 600 to 800 IU, which will be roughly 20 microgram daily you continue. If it is more than 30, the RDA for vitamin D for less than 70 years is 600 IU. More than 70 years, it is 800 IU. In pregnancy, there are studies from 1000 IU per day to 4000 IU per day. Those who are having malabsorption, like celiac disease and other diarrheal episodes, malabsorption syndromes, or they have been operated, then you might need to continue with 50,000 IU per day. Or we need to switch to vitamin calcidiol, that is the liver. If person is having liver disorder, you don't get the 25 hydroxylation in the liver. So you need to supplement either with the calcidiol, which has a better absorption, and it won't need the 25 hydroxylation which happens, 25 hydroxylation which happens in the liver. So you give them calcidiol. If calcidiol is not available, you give calcitriol. That would work directly because it is already active form, which we do in when the EGFR is less than 30. You treat not with vitamin D supplements, you just directly give calcitriol. So liver disease, you give calcidiol. Kidney disease, you give calcitriol. Or calcitriol given directly is the active form. So that's the idea. Calcitriol, the cost difference can be there. The potency and absorption is good with as we go with the higher calcidiol or calcitriol. Monitoring and safety, if you want to do, if you are doing severe corrections or treating severe deficiencies. By severe corrections, I mean if you are using injectable forms of vitamin D, you are using high dose of vitamin D, please do monitor for vitamin D levels. If you can't monitor vitamin D levels, then please check the serum calcium level at least. There have been patients in the follow-up who come with कि डॉक्टर साहब वीकनेस तो बढ़ती ही जा रही है, भूख भी कम हो गई है, सर दर्द भी हो रहा है, वॉमिटिंग भी हो रही है. Because you see, they check the prescription, person is getting vitamin D in injectable form also, oral form also, and somebody has written Bio D3 strong and FAM and this and that to get him moving faster. In the event, what has happened? Person has developed hypercalcemia. Just check serum calcium. If you can't afford vitamin D levels, please check serum calcium. Adequate hydration, wait for few days, the calcium would get corrected. More so when you are treating a patient with CKD, then you are combining, giving them calcitriol, that time you need to be extra cautious. So vitamin D in bone health, it reduces falls, fractures, improves bone mineral density. Then there are certain controversies. Controversies are extraskeletal benefits. Are they there or not? For the bone तो विटामिन डी चाहिए. अब ये इम्यूनिटी के लिए, एंटी कैंसर के लिए, प्रेगनेंसी में एक्लेम्सिया प्रिवेंशन के लिए, सोरियासिस के लिए चाहिए या नहीं चाहिए? This is a bit controversial domain. This is a bit controversial domain which we can discuss later on. And then there is again few literature saying that if you give injectable vitamin D, it rises so fast कि बंदा उठ के चलना शुरू कर देता है. So there is increase in the falls. But I analyzed the data, that's about only 30 patients. It increases the falls, but it does not increase the fracture. So Why the falls are increased? Because the person gets the energy, gets mobilized faster, and they tend to fall. But none of those studies, there was hypercalcemia or calciuria or nephrocalcinosis or the fractures. So we'll discuss sometime that vitamin D controls 3% of our genome. It has VDR receptor is expressed all across our cell lines, and 1-alpha hydroxylase is not there just in the kidneys. It is there in many other 10 other tissues. So you have autocrine and paracrine effects of vitamin D. So vitamin D is important for muscle function, cancer, immune function, cardiovascular. This I'll keep as the last slide for your understanding that how it affects the calcium metabolism by increasing calcium phosphorus absorption, how it affects cardiovascular system by reducing oxidative stress, decreasing RAS and decreasing hyperhomocystinemia, how it helps in obesity by increasing insulin release, increasing adiponectin and improving carbohydrate balance. In placentation, it reduces the chances of gestational diabetes mellitus and eclampsia by increasing EVT invasion, increasing progesterone, decreasing lipid peroxidase, increasing HCG levels and OXA10 gene expressions. And same in the immune system by various anti-inflammatory, pro-inflammatory and anti-inflammatory pathways, because vitamin D is crucial to T cell health, is crucial to dendritic cell health. So there's a lot of data on percentage reduction of COVID severity, 50% reduction in multiple sclerosis labs, 30% reduction in RA severity, and faster TB sputum conversion in vitamin D. In pregnancy, 63% reduction in eclampsia, and 40% reduction in preterm birth, 36% reduction in low birth weight, 60% reduction in PPH. So vitamin D has multitudes of functions. That's why high dose vitamin D is being tried for immunity, infection and anti-cancer. There is a lot of evidence which we found during COVID time. In psoriasis, high dose vitamin D, you will see that 30 to 60,000 IU daily maintained for months and years, the psoriasis lesions disappear. So there's a lot of data, many trials on vitamin D. Few components of vitamin D are controversial, yet to be proven further. But one thing is sure, that vitamin D, apart from bone and skeletal health, it imparts a lot of other benefits, and it has been found to be helpful for the cancer recovery. It has been helpful in the pregnancy. It has been helpful in various other walks of life. And in Indian studies, it has been found that just those 8 weeks is probably not sufficient. Maybe we can go up to 12 weeks of 60,000 units and then continue with almost 60,000 every month. What I say in my practice is 16 Somvar, har bar. Every year, 16 doses of vitamin D. Probably what I would like to keep my patients around 50 or 60 nanograms, because it is absolutely safe. There is very less incidence of hypercalcemia, only 4%, hypercalciuria, 20-23%, even with mega doses, hardly any risk of nephrocalcinosis or other side effects. But yes, hypercalcemia has to be vigilant if you are combining two different forms of vitamin D. So target at least 20 to 30 in all patients. Assess risk populations. Avoid large bolus doses. If you are doing greater interventions, monitor and titrate. So with that, thank you very much for your patient listening.